So, sir, I'll
Yeah.
ask. I'll pick on you a little bit.
Okay.
You brought this up. You got a patient who's has asymptomatic progression
Yeah.
on EGFR TKI. You do a plasma test. It comes back positive T790M. Do you just ride out the first generation TKI, or do you just go ahead and switch
Right.
to the third generation?
Right. So this is kind of what I was saying. So this happens a lot, especially we know T790M tends to be can be a more indolent type of progression for patients. So they can have really slow progression, even to 1 or 2 sites, or even at multiple sites, but just kind of, slow, a few millimeters every couple months of growth. Asymptomatic, and some patients do tolerate it very well, and they have none of these side effects, and they feel fine. So what do you do? And I mean, we don't really know. It'd be nice to have a trial that tells us what we should be doing. Is it better to switch early or try to get as most you can out of the first generation or second generation drugs? If someone's tolerating it really well and it's really, really minimal progression, I watch them closely because I want to switch at the first sign that there's more than just a little bit of progression. But I will try to get the most I can out of it, again, assuming that they are tolerating it well and there's no other reason to switch.
I'm with Marina on that. It's, the squeezing, I think, is the right thing to do. But you look the patient in the eye and you say, is this okay with you?
Yes.
Right.
And if they tell you it's okay, then it's okay.
Yeah, I agree. A shared decision making in
Yep.
this setting is important to elicit, to get the patient buy-in, to understand how we're thinking in terms of the treatment decision. One more question about these drugs, and again, I think there's a lot of confusion in the community. There, as Chandra, you mentioned, there was a response rate in the T790M negative patients, and there's all these questions about whether they were truly T790M negative, or is this just tissue heterogeneity? Did they not accurately capture these patients? Any thoughts on using these drugs in T790M negative? Certainly not the paradigm we're asking for, but the data are the data, at least published in the New England Journal last year.
But the thing is that we also should be cognizant of the fact that they have EGFR sensitizing mutations in addition to the presence or absence of T790M. So those responses may be because of that clone of EGFR sensitizing mutations that they have rather than the T790M. And as we said, that if you're doing liquid biopsies, we may miss it in 20% of those patients. And with tumor heterogeneity, that's the third issue, that we may not be catching that area of tumor where you are able to get the DNA to look for the T790M mutation. And we also know that, as Govindan pointed out earlier, that these may actually disappear or not be present if you take another biopsy or a tissue at a separate time.
So let's move forward now. We're now approaching, perhaps quickly, another paradigm shift using osimertinib potentially up front. There's been some data that was put out at ASCO last year and in Geneva at the European Lung Conference showing very competitive outcomes with using these first line. And we'll also learn, I guess, tomorrow about some potential for it to cross the blood-brain barrier. Govindan, you want to give us your perspective on using this drug up front, treatment-naive patients and EGFR-positive patients?
Chandra mentioned this before, but what is impressive is that this is a small phase 2 study of 60-plus patients, osimertinib given at a couple of different doses. It's striking that 70% had a nice partial response, 97% had disease control rate, and the median progression-free survival was approaching 20 months. This looks very much like what we see now with some ALK third-generation inhibitors. And that, I think, is pretty impressive, and that, as Mark said, comes with very acceptable toxicity without all the rash and diarrhea, et cetera. So I cannot imagine a scenario down the line, 5-10 years, we will not be using more mutant-selective inhibitors. And I think this is the first step in that direction.
Okay, and how do you see EGFR TKI sequencing really happening now?
Right now, in the absence of data, in the absence of other drugs to follow through, I think what we're doing, is reasonable. And by the time our patients begin to progress, they've learned to tolerate erlotinib if they're doing well, like what Sarah said. I think really we will definitely have use the drug in a particular way, sequence them to the extent they can tolerate, and then use at the time of disease progression.
Yeah.
I think osimertinib at the time of disease progression. But eventually, when we see that these drugs are better in the frontline setting, we'll probably be using it differently.
It'll be interesting to see, progression on osimertinib. We've had some recent small case reports about this new mutation, C797S, which may predict sensitivity, oh, by the way, to first generation TKIs. So
provided. It depends on the context in which these mutations happen. And unfortunately, the C797S may be present along with T790M, then it's a tough thing.
Right.
If that subclone of T790M disappears, potentially using the first generation EGFR TKI may be helpful. Again, we've seen similar thing with ALK, where patients who progress on alectinib may now suddenly be responsive to ceritinib while they had received it a while ago. So I think we may be seeing those kinds of things, showing once again how dynamic the tumor evolution is, how much we force it to change in response to treatment-induced pressure.